Thank you everyone for attending such a special conference, the Wounds Canada Conference being the 30th anniversary. We're obviously really excited to be here and look back at the history of the conference and how far it's come. So thank you all for being here and at the Essity Symposia this morning. My name is Daniel Scube, the Key Account Manager for Essity in Ontario. I know you're all on the edge of your seats waiting for me to present, but I won't bore you all to death. I will let the experts here take it over in just a moment. Today we will be going over wound wisdom from first steps to mastery, and please help me introduce Rosemary Hill, Amanda Sobiak, and Karina Owen.
Well, it is really great to be here. It was fun earlier this morning when we would stand up and sort of say, how far back did we go? And I remember, you know, it's flashing back, of course, for me, just a few years ago. Well, maybe more than just a few. But I remember attending, I think it was like 2002, and Gary Sibbald was doing a presentation, and we had little controllers, and we could answer, and you could see the answers on the screen. And I remember thinking, wow, this is amazing. This is the best conference I have ever been to in my entire life, and it truly was. And from there on in, I was a committed follower of attending as best I could to Wounds Canada. So anyway, that was my little flashback to the past, although later on you're going to see a few more little flashes back to the past. But let's get on with what we're going to talk about today. And you know, we'll make sure that we have time for some questions as well. So actually, you know what? Wait a sec. I want to tell you what we hope to cover in the next hour, all right? So we're hoping to offer you some new clinical pearls, let's say. But most importantly, we want to showcase the versatility around the dressings that we're going to be talking about. And we're going to start also with sharing case studies. But the uniqueness about the case studies is there are some from Lionsgate Hospital, Vancouver Coastal Health, but then also from Amanda in the rural setting, and she'll talk a little bit more about that in Alberta. And then we have Karina here from Ontario. So there's a little sprinkling around the various care settings. So, you know what? Time for a polling question. And this is, to me, I find this absolutely fascinating. And I think also we can target our talk knowing how many years you've been in wound care. So we can sort of get a sense of, does the room hold a lot of newer practitioners, or is this a room full of seasoned wound care champions and leaders? So let's go to our app, and you're going to go to that polling, and I wonder how this works. Oh, there we go. Aha. I'd like also, we'll take a picture because I'm curious to see. We do have quite a few more newbies. Yeah. All right, that's great. So I'm going to make sure as best we can, I want to be really clear in how we communicate the types of patients, the people we meet, and how we want to work on what's best for them and the type of dressing for them and for their wound. But here's going to be something interesting. What was the greatest thing since sliced bread when you started your wound care practice? What was there something? And now we're going to get a bit of a word cloud. I'm going to take you back to my beginning days, just briefly. But you know what the first thing for me was? Duoderm. It was the first thing. Okay, I heard the giggles. I might have been dating myself just a little bit, but truly, it was like, wow. This helps with a moist wound cleaning. Okay, let me just see. Is the word cloud going to pop up? Oh, I don't want to go back to case studies yet. Let's see if there's a word cloud. Just put in a word for what was the greatest thing since sliced bread. Maybe, I don't know if it's coming up. Oh, you know what? We're not going to worry about the technology piece, but at least you had a little giggle with the Duoderm. I went, oh, there we go. Foams. And do you remember when I used to talk about foam, often people thought it was like a foam cleanser, Like they didn't realize that it was a foam. It was an absorptive product. Wow. Oh, interesting. Yeah, wow. Tegaderm, you're right. That was in my era too. It was one of the first, that transparent dressing that came out. That was really big. But again, that's just a few years ago. Anyway, we got to get pictures of this. HFB, I like it. A little bit of hydrophoroblu. Okay, what I'm going to do now is I'm going to hand things over. I'm going to pick up the tail end of our presentation today and share with you from cases in Vancouver just at the end. But what I'd like to do is hand things over to Amanda. Last year, or earlier this year, Amanda and I got to speak and just share all our various encounters with the different scenarios with our patients. But Amanda, why don't you come on up and let's chat with the group and share your learnings.
Thanks, Rosemary. Okay. So to progress, I press the green
button.
Okay.
Green is go.
Okay, wonderful. So welcome. My name is Amanda Sobiak. I am a registered nurse who works in Alberta. I actually work for a reserve. And so I'm hired by the reserve for the reserve. Am I loud? No, I'm okay. Okay. I'm hired for the reserve, by the reserve, and I have a wound clinic that we've opened up there. So it's really exciting. And let's just see what I've got to show you next. So this is me now. This is me the way I look. 30 years ago. This is me at 15 years old, so you guys can figure out the math from there. So that's me at 15, and unfortunately, I was honest, and I used an exact date 15 or 30 years ago. This is the only picture I have, and that's why. So from 15 years, of course, we've learned a lot. I did want to, and in all the presentations, which I think is really interesting, we've gone over the wound bed paradigm. And so I just want to acknowledge Woundspedia in creating this document, and that it is something that we are obviously all using. And it is something that is important, especially when working with hydrophoroblu, because we can look at 4 of the different areas with that wound bed. So we've got debridement, infection and inflammation, moisture management, and edge effect. So the Hydrophora family has multiple wound care products, obviously, all having that pyovinyl alcohol or that PVA foam. It's non-cytotoxic and antimicrobial. It's a natural negative pressure. Say that twice. Natural negative pressure. It has natural autolytic debridement and helps flatten those rolled wound edges. So hopefully throughout this presentation, you'll learn how we use these products to address all those 4 areas. So when we're looking at debridement, there's multiple types of debridement. I'm speaking with a bunch of people who know this, so we're not going to go through a lot, but we do want to just acknowledge that hydrophoroblu really focuses on that autolytic debridement. So here's a case study of mine. This is a gentleman, he's a male, Indigenous or First Nations man with a right leg amputation. So he had a prosthetic that was ill-fitting, and I don't know how many people work in rural settings, but getting out to have your prosthetic fitted and refitted is a process. And on reserves, we have a lot of problems with transportation. So as you can see, this gentleman obviously did not make it back for his fitting, and he had a wound. So we have some undermining and some edging that you can see, but the undermining was fairly minimal, and with a little bit of help, we were able to get it a little bit less, but you can see that rolled edge, and that could have become a big problem. But I tried the Hydrophoroblu Classic, and I went over the edge a little bit more, so about 1 centimeter over the edge. Something that sometimes, I know when I first started using Hydrophoroblu, they said, don't do that. You can't go over the wound edge. You can, it's okay. Of course, monitor, you're gonna wanna look at this wound and make sure that you're not having any pressure, but it worked very well. So we just cover it on up. Look at that. So I know it's not a pretty wound. Not everything we do is perfect. Our patients aren't perfect, and neither are we. Unfortunately, our gentleman who has diabetes had poor control and ended up with an infection. But look at that circled area. That was the wound. So that edge effect, we definitely were able to bring up that wound bed and flatten those edges. Of course, we did treat this. He got antibiotics, and look at that. So at this point in time, I switched to Hydrofera Blue Ready. And that's because the exudate, of course, had decreased. And when we have a lot of exudate, Hydrofera Classic is a fantastic, or we'll talk about some of the other products that are amazing. So when we have to really pay attention to that moisture balance, and at this point in time, I didn't have enough moisture, so we had to switch to the Ready, which is a softer product. Here's another case study of mine. So this gentleman is housing challenged. He misuses narcotics, and he was a victim of street gang violence. So he was jumped on the street corner, and a needle was put in his neck, and he was set on fire. Thankfully, he doesn't remember the fire. However, he woke up in the hospital, and his arm was very burnt. Unfortunately, home care had been working with this wound for almost a year by the time I saw him. And this wound was very painful, and you can see he has MRSA, you see that crusting on those wound edges. But the biggest thing I want to say, this was a very painful wound, and a client that's hard to keep track of. So, of course, I tried what most of our nurses were using, and we tried the hydrofibers, and we covered it with foams, and we did all those things. Now you can see there's multiple pictures. This is one arm. It's not multiple arms. It's a circumferential, and the nurses had done an amazing job overall. You can see a lot of scar tissue and a lot of healing happening here, right? But that main area had remained open. So I tried Hydrofera Blue Classic. Now that's not something everybody thinks about to put on a burn, but after a year, you kind of think, you know what, let's just throw everything I can think of at this gentleman. We had an infection, or we had some, oh, my brain just went blank, sorry. We had a lot of bioburden in that wound bed, and so we needed to address the infection, we needed to address the edge and the moisture. So when I'm looking at this, I did cover it. Now the first picture is the back of the arm. I'm sorry, it's a little out of sync, but the end picture, you can see the wound bed, and you can see how the moisture has been managed way better. We've got wonderful granulation buds happening. I don't have as much crusting at those edges with that MRSA. And on the Hydrofera Blue, you can see it's almost like a perfect mirror image. And when it turns white like that, it's lost its fight. So when it turns white, it's lost its fight. And that's a great thing, especially in community, to tell nurses and clients, you know what, when it turns white, that just means that the dressing's done its job and it's time to change it. If the home care nurse takes off the dressing and it's still blue, we still have some fight left in that dressing. Maybe we could leave it an extra day. So as we progressed with him, it was healing quite well, but he would disappear for periods of time. But it was really interesting, even though it was a classic, he found it more comfortable. So he came back more regularly. I then switched to a transfer, and the transfer is soft and pliable. So I don't know how many people have used Hydrofera Blue, but the classic is hard, and you have to moisturize it first before you put it on the wound bed, whereas the transfer is already soft. Okay, so we had less drainage because we had healed so much that I was able to switch to the transfer and gave it a cover dressing. Now, I'll be honest, he disappeared for quite a period of time, and I thought, you know what? I've done everything I can. When he's ready, he'll come back. And he did. He did come back. And this was on April 16th. He showed us this. He disappeared for a little bit, came back again, and he was healed and closed. So that was a really great case of Hydrofera Blue and using it on a burn, which is not something everybody thinks about. An infected laceration. So this lady is 30 years old. She cut her leg on some glass, actually escaping a window. So she's non-diabetic. She doesn't have any other comorbidities, but this was a highly infected wound that was draining copious amounts. So when we have something like this, we could go for a Hydrofera Blue, but I was thinking, we've got an infected wound, it needs to be seen. And I used a product called Salt. I know I'm talking about products, but it needs to be changed every day, right? I wanted to get that bioburden out. So that's what I did, and you can see how that wound progressed. And we have those granulation buds, but we still have a little bit of slough in that wound bed and rolled edge. So this is when I did put on the Hydrofera Blue Classic. Now, the dates on this is what kind of makes me happy, is how quickly we went from an open wound to a closed wound. It went very quickly, and it was very little pain. This is something that I hear over and over again with my patients. Can I have the purple stuff, Amanda? I get it all the time. Can I have the purple stuff? It doesn't hurt as much when you put the purple stuff on. That's a good product. Now, this is one of my favorite patients, and some of you may have seen this before, and I'm sorry if you're seeing it again, but this gentleman is a hunter. That's big in my community, of course. He's a hunter that stepped on a nail, and he has diabetes, and he doesn't feel his feet, obviously, he's insensate, and he showed up with this massive ulcer. He ended up going into the hospital, and he was on the surgical table. They were about to remove his foot. And I don't know what happened, divine intervention. The surgeon decided to have a little powwow at the end of the table, and my client was sitting there watching them, and that one was, I think, no. And all of a sudden they came back and said, you know what? We're gonna wait. Let's give your foot a chance. I think that there's an opportunity to save this limb. And so they let him go. Now that's only as good as the team is, right? So this is how they let him go, unfortunately. So he did come back from the hospital because they said VAC failed. I'm sorry, but VAC failed. Now, I do live in a rural community. Not everybody's familiar with all the products out there or how to use them. So did it fail, or was it just user error? I don't know. It doesn't matter. He showed up like this and we had to deal with it. So I, of course, sent him back to the hospital. Unfortunately, it was Valentine's Day, and my gift to him was, you need to go back and get some antibiotics, please, and then you can come see me again. So he did come back, and I started using HydroFerroblu. I used it right from the get-go with him. We're looking at debridement. We've got that autolytic debridement going on. We've got moisture management going on. The edges, you can see the epithelial tissue coming in from the edges on this. Now I also used, you can see this one's kind of a circular, and I went right through. The doctor at the time didn't believe me that it was going right through his foot, and I'm like, it's going right through. No, I don't think it is, Amanda. I'm like, yeah, I'm pretty sure it is. So I probed and went right through his foot. And at this point in time, if you have a patient and you've just discovered this, you can imagine how scared he was. I was just about to lose my foot, Amanda, and it looks so good, I don't understand. How are we here? Well, we're here because we are, and that's okay. Let's see what we can do. I wasn't necessarily always, you're not always prepared for what you're seeing when you go into a wound, and you need to be able to kind of go into your toolkit and pick the best thing that you can, right? And HydroFerroblu has become that thing that is the best thing that I can, because I can use it in so many ways. So I can take a classic and I can cut it, and you'll see me do this, and go right through the foot. So if I have one piece of classic, I can do multiple things with it, which I really like about this product, and this is what I teach my home care nurses. Make sure that you're prepared. We all know we have to be prepared, but sometimes we just need a one product to be able to do multiple things, because my bag is full. So you can see I went right through the foot. Be careful with this. When we're going through a tunnel, of course, we know that we want to move that exudate out. We want to help clean up the wound with the autolytic debridement. But wonderful things are happening in there. We've got granulous tissue growing, right? But if we keep putting something through a tunnel and it's trying to grow, there's going to come a point in time where the patient might have more pain when you remove it. So this is where you start to do some creative things. So here's a picture of my HydroFerroblu cut in many ways. This is one piece, one 4x4 piece that I used in multiple different ways to help with this wound. So this is where you get creative and you start doing a tunnel from either end. So I'm sure many people do it, but I'm always teaching my home care nurses, remember, we do this for a period of time, and then we start going from the edges. So you can start going from either end to actually help that granulation and that tissue expand in the wound bed. I'm happy to say this is him recently, September 25th. It was a large wound. This has been a long, arduous process for him, but he has his foot, and he's really, really happy he has his foot. He has made mistakes along the way, and that's okay. We work with our patients, and we're a team, right? We can't do it for them. I have a sign in my clinic that says healing is your journey, and it really is their journey, and we're there just to help. So when we're talking about different products that are available, I just wanted to highlight this one because it's something that's kind of new to me, and it's the FeraWrap. In communities, many communities have HCAs or aids that can help with donning and doffing compression stockings, and we know that's kind of like the gold standard. We need to compress. However, in my community, we don't have any help. So I have a lot of elders that are trying to put on compression stockings with arthritic hands, and they just can't do it. And it's hard to put on. I don't know how many of you put on compression stockings. I do. I struggle. And you get it halfway up and you need a break and it hurts, and then you're like, oh, just screw it. I'm going to take it off. I'm not wearing them. And then you have non-compliance or clients that don't want to wear them, right? So this is a different option. And it helps, of course, with that lymphedema, the peripheral vascular disease, heavy swollen legs. It's easier for donning and doffing. It increases comfort. It's a nice material, and it supports independence. And that's the number one for me. It supports independence. It's a 30 to 40 millimeter compression. But the other nice thing about it is that when we're looking at waste and being more environmentally conscious, usually with the traditional 2-layer wrap, you're changing that 2 to 3 times a week, right, per leg. So that over 6 months, that's up to 72 bandages. And if you took those bandages end to end, we're looking at 1.8 CN towers, or 914.4 meters in height of clinical waste in the landfill. It's quite significant. And I don't know how many other communities kind of, oh, you're in compression, we're just gonna leave you on that, and we're gonna do that forever, right? Because they're not going to wear their compression socks. So we're just going to do this forever. That's not a great use of any resources, nor for the environment, right? So here's a lady of mine who I decided to try the FeraWrap, the Jops FeraWrap. So this is a classic. And if you look at the first 2 pictures on the top, it has a liner, which is just a nice stretchy sock that a patient can put on. Now you can see she is on her back, and she's doing it how she would do it at home, because that's reality. How many people can bend over from the waist easily? She's laying on her back and she's pulling. With a compression sock, how many times do you get a run? How many times do you have all those other issues? So she's pulling and she's able to do it on her own. The next 2 pictures, that has compression, but the compression is only in the foot and the ankle. So that's kind of nice because we have foot and ankle compression with less bulk, and they can pull that on, and it's only hard at the very end, and she didn't find it that difficult at all, actually. And then it was a matter of taking these Velcro straps and going across. Now, I have had patients with the Classic that find multiple straps, it kind of falls, it can be challenging. So I was really happy to learn about this next one, which is the 4000. So again, you can see he's got that compression on the foot and the ankle. And I'm gonna tell you, as this video is going and I'm talking, this is the very first time he's applied this, okay? All on his own. So he's gonna take this next part of the wrap, the 4000, and you can see that there's a bit of a sleeve. And here's the take-home message, because I had sent him home with his home care nurse to do this, and he said, it doesn't work, Amanda, I can't make it work. Like, really? Come talk to me, come to the clinic. Will you come to the clinic with all your supplies? He's like, yeah, I'll come. He comes and he shows me, and he was putting on them backwards. Okay, so just having those conversations, making sure everybody understands how this works, it's intuitive, but we still need to support our patients where they're at, right? So you can see him, he's putting the sleeve on the right way this time, and he's able to bend over, but he's also able to take breaks. So with compression stockings, when we're putting them on, sometimes those breaks can be painful, and this isn't for him. And then it's just a quick Velcro. Here he goes. You can see that he has the Velcro tabs flipped down. That's so it's not sticking to itself, and it hopefully goes on nice and smooth. Just one of those little tricks. So he's able to put it on and gets it on very well the first one. I videoed him doing it the second time. He did it even better and faster. And he's like, oh, that's actually pretty good. That's not bad at all. Again, we're looking at that 30 to 40 millimeters of compression. The other thing that I really like about this is I don't know who else has had somebody who you take out of a 2-layer compression, and that's that short stretch. They're doing fantastic. Things have healed. We're ready to move on to compression socks. We put them in a compression sock. Maybe they wear them, maybe they don't, but say we have a perfect patient and they're wearing them and their legs fill up with fluid again. And you're like, what's going on? This is supposed to be helping them. But sometimes that's the difference between an elastic and an inelastic compression. And some patients just need that inelastic compression. That's FeraWrap. It's easy to put on, it's inelastic, you don't need multiple clinicians to do it, and they can do it on their own, which I love, especially being in a remote community. I'm gonna pass it on now to Karina.
Thank you so much. First of all, I want to say it's a bit of a surreal experience to be up here with Rosemary and Amanda, two clinicians whose work I've listened to at conferences and even cited in my undergrad and graduate studies, so very exciting. This is me, obviously, today, and 30 years ago, I was still loading, so I don't think my parents had even met yet. Wasn't even a thought. And this is a poster that I had for the NZOC conference this year. This is available in your packages to see here, and we're going to talk about these cases. So this first patient here, this was a 51-year-old lady who had undergone initially a liposarcoma resection with a total hip replacement, and that was back in 2011. At this point, she had multiple revisions due to infection and eventually a girdle stone procedure where they actually removed all of the hardware, including her femur and her hip joint prosthesis. And what was left was this wound, which they kept open to treat and clear that infection before any further surgical procedure. So a very extensive wound. She did have quite a few comorbidities. She was a long-term smoker. And she came to us to rehab where I was working at the time with this wound. Very extensive, about 8 centimeters deep. Her pelvic bone was actually, you could feel it when you probed into the wound bed there. So really an extensive wound. She came with traditional negative pressure, but there hadn't really been any change in the wound with that on, and it had been on since her surgery, which was, I think, about 2 months prior to her being admitted to us. And so thinking back to our wound bed paradigm, you can see in this first photo here how much non-viable, sloughy tissue we have. There was quite a bit of granulation tissue that was really just not healthy looking at all. Very pale, very devitalized, and again, a ton of dead space. So I really wanted to keep her on the negative pressure, but obviously wanted to treat the bioburden and help with that granulation tissue formation. So I started her on some hypochlorous acid as a cleanser, and then what I used was the Hydrofera Blue heavy drainage. And if you don't know what that is, it's part of their classic line, but it's a very thick, very porous version of the classic. So it does need to be moistened with either normal saline or sterile water. And one thing to note about it too is when we use it with a hypochlorous acid or an oxidative cleanser, we do have to be a little bit careful because, as Amanda said, once it's white, it's lost its fight. And those two products together, what you might get is they turn white when they interact. So we do recommend you rinse off either the cleanser with normal saline or sterile water or just really pat it dry very well. So the heavy drainage takes a lot of solution as well. For me, I was using about 118 milliliter bottle of saline to really wet it down, get it to that pliable, soft state that we could pack the wound with. And that came with some troubleshooting under the negative pressure. As you know, getting a seal sometimes very difficult. This was on her hip, so you can see the folds, the creases, a very difficult place to get a seal anyway. And so a little bit of trial and error with wringing out that foam, really taking your time to make sure it's not sopping wet, it's not dripping, and that you're not going to have any leaks with that suction, trying to just spend time pulling the fluid away. So we got that started. We were changing it twice a week at this point, and you could see from the first photo, really like about a week later, how much less that sloughy tissue is. There's some good granulation buds in there, and we actually even had quite a bit of a decrease in depth, which was really impressive given how large this wound was. One thing I do want to mention, speaking back to the quality of life piece, this lady was independent. She was moving around well. She used a walker. She was also a mom of 2 and a teacher. And she had her career and her life on hold for over a year. And when you look at all of her past surgical history, really a lot longer. So she was really anxious to get back to her life and, not be dealing with something like this. So my goal was to get this as small as possible, and hopefully she could go back for more surgery to fix this. And so we did this for about a month or so, and you can see in the last photo, although of course nowhere near full closure, the tissue quality is so much better, the edges are so much better. We actually had about a 2 centimeter decrease in wound depth altogether, which was really, really significant. But what was even better was that with this combination of antimicrobials, the negative pressure, she actually remained infection-free without any additional antibiotics, which was huge. And she also avoided an additional surgical debridement procedure, which was initially anticipated given her infection status and the way the wound was looking at the time. She did go on to have a hardware reinsertion, and they were actually able to close this with a flap, which was really great for her, and she actually went on with good success with that. So really, really great stuff with that. This second case kind of piggybacked on the first one. She was admitted to rehab within the same year, and so everything was very fresh in my mind at the time. But this was a 71-year-old woman, also very independent. She lived alone. She was really concerned about how she was going to continue having had this transmetatarsal amputation. And she had this procedure after an extensive gangrene, which developed from vasopressor use in the ICU. So really an unfortunate circumstance and something that was really unanticipated for her. I think she initially was admitted with just a simple pneumonia that progressed. So a big shock for her, and really wanting to get this closed and get her home as soon as possible. And again, you can see the wound bed, very sloughy. There's even some kind of what looks like eschar there, and the wound edge is very macerated. She came with just a conventional dressing, and I thought, you know what, let's just use the same recipe I had from the last case. And so I got her again with that hypochlorous acid cleanser, we got the heavy drainage on, and then the negative pressure on top. And by this time, I had things down to a science. So the application was a lot easier. Once you get the hang of it, it really, really was just like doing a regular negative pressure dressing, which was great. And we were actually able to use the hydropheric heavy drainage in place of the traditional granufoam, which if anyone's ever worked with negative pressure, you'll know there's not many things that you can really use to replace that granufoam. And there's not many options with the granufoam, right? You've got your silver, your white, your black, and that's about it. So yeah, this was a really interesting product for me to use. And after the first application, you can see this photo, the initial photo, is a little deceiving because really this wound was about 2 centimeters deep. The very significant chunk of her foot was missing. And after the first application, down to about 0.5 centimeter of depth. So a really incredible progression in such a short amount of time. And she was with us for about 2 months, and eventually that final photo, I think, really speaks for itself. A huge improvement, and again, giving her back her independence. We were able to discharge her home we had to switch her to traditional negative pressure. Unfortunately, the heavy drainage is not yet available in the home care formulary, at least in Ontario, so hopefully that changes. But yeah, we were able to get her home with a custom offloading shoe with the regular negative pressure, and she did really well. So yeah, great success with both of those cases. Now we'll pass it back to Rosemary.
Thank you, Karina, for her inaugural presentation. Well done. Very, very huge, large wounds, and they take a lot of patience. So great. All right, so here we go. And all right, so now we're gonna, we really want to highlight this theme. 30 years is something amazing for Wounds Canada. And so we kind of let ourselves be a little vulnerable. And I thought I would show a picture. All right, you're doing the math really quickly. Clearly, it was more than 30 years ago. But that's me as a nursing student. And actually, it was Vancouver General Hospital. We wore our caps then. I'm just curious, when I graduated, I wore a cap. How many in this room wore a nursing cap when they graduated? Okay there. Yeah, a little sprinkling of us, yeah. But it's interesting. I mean, when I think about it now, I think, what? You were wearing a hat, but those were the times. And so I'm also going to give you another little thing. When I was in the ICU, I spent the first 10 years of my nursing career, or actually 12, in the ICU. And I was just like literally late 20s, and I'd read this stuff about oxygen therapy. And I remember one day, in fact, it was ICU bed 5, I said to the girls, you know what? He's got this pressure injury, but I've heard oxygen, it really works. So I just grabbed some oxygen tubing, I put it through the end of a styrofoam cup, I got the patient to lie on his side, and I let that styrofoam cup blow oxygen right on his wound. Okay, so clearly I was not a scientist person by a long shot. It really dried out the wound. And everyone went, well, I think it looks different. Yes, it was very dry. But anyway, it's funny looking back. But we learn so much, too, when we look back. But anyway, let's go forward. And let's just talk about some of my cases at Lionsgate. And these are actually relatively recent cases. And particularly, I wanted to share the story of Mary. And what happened was she was having a nice dinner with her daughter, and by accident they had a carafe. Now, it might have been a carafe of wine, but let's not worry about that. But by accident, the carafe hit her leg, and she was on blood thinners. And all of a sudden, lo and behold, she developed quite a hematoma, and then she was brought down to Lionsgate Hospital. And I remember literally seeing her in the emergency room with Dr. Chu, and we just looked at this leg, and there's so much clot. Now, Mary was an elderly lady. She was in her early 90s, and actually, she lives in Squamish, and that's a bit rural, but and she'd been on home oxygen for the last year. So she was on home oxygen and obviously on blood thinners, which we held and began to start dealing with this clot. So what we did was, first of all, with Dr. Chu's expertise, we cleaned that out carefully. You know, one of the things to this day I'm still puzzled about, that she didn't have huge amounts of pain. So I'm not sure how that works, but it was relatively easy for us to irrigate. We did give oral analgesic prior, but you know, we had to watch this and wait for it to declare itself. And do you see how it then, that tissue on the edge became quite black? And we realized it was time to take her to the OR and do a proper debridement and clean it up. And Dr. Chu asked me to join him and to put on some negative pressure wound therapy, which we did. And you can see already it was started to clean up. But you know, as we get to know our patients, and we talked to them, and her daughter was always at her bedside. But one morning, shortly into doing our vac dressing changes, she said to me, you know, Rosemary, this is a really, really big wound on my leg. I've never had anything like this before. And she said, I want to let you know that I did sign the papers for MAID. And I went, oh. And she goes, I did it before this happened. I did it before this happened. And I'm going to meet with a social worker. And I said, okay. But she said, you know what? I'm not saying I'm ready yet, but just let me know what you think about how this wound is going to go. And she said, you know what? I really, really want to go home. That's all I want to do. Please just get me home. So I said, okay. So what I did was I did just about a week of negative pressure wound therapy. And then I said, you know, look, I have another product. It's a product that I think will get you home. And both her and her daughter, there was a chorus of yes. That's all we want, Rosemary. So I said, okay. So what I did was I used something called the hydropharablue transfer over the wound bed, and then an absorptive dressing. I don't know if any of you have heard about it. I've just been using it lately when I have some really legs that are really weepy and exudative, and it's called Sorbian XL. And literally it just wraps around her leg. And then I did a Coban wrap over top. So I said, you know what, tell you what we're going to do. We're going to do this on Tuesday, and then I'm going to look at it in 48 hours. And if it's good in 48 hours, you're going to go home. We're just going to send you home on Thursday. And so, but I wanted to make sure it was a good controlled way. I wanted also to make sure that when we removed it, she didn't have a lot of pain. And so that's exactly what we did do. And on that Thursday, she went home to Squamish. She is still home in Squamish, doing well. Yes, albeit, oops, I'm going to go back. Yes, albeit she's still in her home oxygen. But can you see the effects of just the transfer, the absorptive pad, and the Coban? Gorgeous granulation tissue. It's just starting to get some epithelial islands at the bottom. I haven't put her recent photos in. But you guys seen the Sorbian? Yeah. Oh. It's
I'll
not
just
on?
come up to you.
Come on. Oh, it's on now, I think. It's on now. Go for it.
Okay.
Sure.
I just wanted to say, so the Sorbian XL is quite an amazing product for community. When you're looking at it, it absorbs up to 2 liters. And like it honestly is 2 liters. The other thing about it is it's beautiful around the leg, the way Rosemary did it, but I've also used it and made a boot out of it. So you got to get creative in community. All my home care nurses know we're good at arts and crafts. Arts and crafts is great for this, but you don't cut it, okay? You can't cut this product, but you can mold it and you can make a boot. Just want to put that out there.
Thank you. I like these little additions, these pearls. Okay, so I now want to share with you just again the versatility of this particular family of products, and just how I'll use them with other situations. So I do have an ostomy clinic, and I had this lovely lady with her loop ileostomy. She developed a peristomal ulcer, and so I took the time just to use something called nanosalve, which I think you'll see in the exhibit hall, and I popped the ring on top of that. Just a thin layer, pop the ring, and the ring is a lovely way of absorbing the exudate because you need your flange to hold. It needs to have a dry landscape. And so, again, I just thought I'd sort of throw some cases at you where there's a variety of uses to the Hydrofera Blue, and it comes as a ring, but also Amanda talked about the tunnel, and then there's various types of absorption, whether you're using the classic or the heavy drainage. And of course, the ulcer went on to heal. Came across this diabetic foot ulcer, and this was a bit tricky. Yes, diabetes, type 2. No, it was not a very good hemoglobin A1C of 13, and he had been in a boot, work boot, and it was rubbing, and of course there's 2 open areas, irrigated those, and just actually worked with the family of Hydrofera Blue products. You know, at one point I know a nurse said, oh, can we not just go ahead and put a skin graft? But you really can't put a skin graft on top of tendons. You just have to support the surrounding wound to see if you can get some good wound healing. And so we did. We stayed with the Hydrofera Blue. Then we flip-flopped back and threw on some Prisma and Transfer. But when you look at the whole case, we certainly got it closed, which is amazing when you think of something where you needed granulation tissue to go over that tendon. But again, variety of products, classics, ready, and then Transfer when it came to supporting wound healing over the tendon. This was another lady. She was just a couple of years younger than me. She noticed a funny little growth on her lower leg and thought, you know, I'm going to go to my local derm clinic. I'm worried it's a skin cancer. I'm going to get that taken off. Well, I met her, and she, by the way, she took photos. I find a lot of my patients now are taking photos of their wound. I find it so helpful. She presented to emergency like that, and it was a really nasty infection, full thickness wound, which I did a bit of debridement, and then started with our usual classic, okay, and got it to fill in really nicely, to the point that the plastic surgeon said, well, you know what? There is this product out there, DermGen. And so we put that on, but we used the Transfer on top so that if there was exudate, it would transfer that exudate and not burden the graft. And then she went on to epithelialize as well. So I'm just saying there's quite a bit of versatility with the family of products. Again, this is now flashing to the future. You see, I obviously have a thing about oxygen, breathing new life into wounds, but I did use oxygen therapy with this gentleman, Now, the thing is, when you use oxygen, you'll notice, first of all, the wound gets a lot of exudate. And I had to think about how to manage that exudate. And so I did have to shift to use the heavy blue classic. Because you see, or heavy drainage, the classic heavy drainage. Because the classic itself couldn't handle all the moisture and the wound edges got macerated. So I switched over to the heavy drainage, which could handle more of the wound exudate. Although additionally, I used a dressing on the sides, a soft silicone with a patented dimple technology, which was also helpful at bringing up the exudate. Now, you know what? Talking about the flexibility, also I do see children in my practice at Lionsgate, and there was this young 13-year-old boy who had a foosh injury. A foosh injury is when you fall on an outstretched hand from his scooter. And so they took down the cast, and so he had quite a bit of road rash. And it really, well, the smell wasn't good, the tissues weren't so good, so we said, what are we going to do here? Clean the wound, some really good wound hygiene, and then we just put transfer. I put a piece of transfer over it, piece of foam, and then bundled it up because he still absolutely needed immobilization to that wrist, and then saw him a week later. And again, actually, did the same thing. So it's kind of nice to explore those options. Sometimes we use the transfer around trach sites or feeding tube sites. So there's a lot of uses when you think of the variety of products that family line of the Hydrofera Blue offers you. So, any other words of wisdom from the field here as we look back? I don't know if both mics are on, Karina or Amanda, you can share the mic. Any thoughts when we look back as far as how far we've come? Looking back 30 years ago, the Duoderm girl, to?
Well, given that I've got about 3 to 5 years of experience in nursing in general, I think it's really incredible the variety of products that we have. And even just going through this presentation together, the three of us, I've learned so much about the different products and uses for the products, right? Like even the FerroWrap, not something I would consider coming from an acute care background where we do have the resources to get staff to help patients, apply double layer compression, but thinking forward to them becoming independent and going home and reducing the resources for home care as well, really huge, especially in a big city where that's frequently where our patients end up. So yeah, just really interesting how far we've come and the innovation with it.
Absolutely. The thing that I love about Hydrofera Blue family, especially coming from a home care perspective, is really the versatility of it. But the versatility of one square of classic. Being able to go into a wound and not know what I'm going to step into. Am I going to have to tunnel? Are we going to have undermining? Do I have rolled edges? How am I going to do this? I feel like it's kind of like my Swiss Army knife or my little powerful packet that I can take that one piece and teach my home care nurses, you know what, if you've got nothing else, please make sure you have one of these in your back pocket, because we might be able to do something that we would probably need multiple products for in one. And as home care nurses know, we love our arts and crafts. So we can do a lot of really versatile things. And if anybody wants to talk to me later about how to cut it in different ways, that is my jam. I'm all about getting between toes and all that stuff. So yeah, it's a great product.
Thank you, ladies. I was thinking, you probably don't know this, but, well, I'm an early riser. And so I watch CTV Morning. You guys have a great CTV morning show. And sometimes, I might even be up at 5 a.m. But yesterday I was watching it, maybe in anticipation of coming out here, and they were talking about how today, actually, it's coming out, for those of you who are foodies, the Michelin Guide for Canada is coming out today. And they were talking about hoping that's, because I'm from Vancouver, that one of the restaurants we might gain a restaurant with 2 stars. Now, clearly, Ontario, I think you do already have a place with 3 stars. But as I was listening to it, they were saying, they had a person speaking about the Michelin Guide. And they were saying, what is it about? What is it about that? Tell us a little bit about more Michelin stuff. And essentially, the Michelin Guide is about places where there is quality, there is value, and there's consistency. I didn't know if you knew this, but the Michelin inspectors, they don't just come in once. They sporadically come in over 4 or 5 times to that restaurant because they're looking for consistency. They're making sure that this restaurant, when they give it a 1-star, 2-star, it performs all the time. And I thought, as I sat there thinking, wouldn't it be cool if there was actually a Michelin Guide for wound care products? Wouldn't that be good? Maybe that's what I should do if I retire, if. And I thought, I have to say that I do feel the Hydroferro Blue, it fits in there in the star category with Michelin, because I love that my patients don't say that it's going to burn and that there is that versatility. Now, one other thing I've done, really off the charts here, was I decided coming today that I would do an Instagram account. I thought that, as I continue in my years, I want to share my learnings. And so I've created, and I've already just started posting today, and it's called, what is it called? I know, it was so new for me. Hills of Wound Healing. I thought I'd take the last name, Hill. So Hills of Wound Healing, all right? You look at that little Instagram account, and I'm going to start posting things from this wound conference, things that really, make a difference, the tips, the tricks. And so Heels of Wound Healing, go to your little Instagram account, and Rosemary's going to start posting. I already, very kindly, Dr. Keith Harding posed with me, so I thought that was a good way to start.